So good morning everybody. Last time we talked about penicillins. As I told you, they are all beta-lactam antimicrobials. Important group is penicillins and another is cephalosporins, related, but they are related in mechanism of action, but otherwise there are lots of differences. So we'll talk about other beta-lactams today. This is cephalosporin. This is beta-lactam ring. In penicillin also this was same. So what is the difference? If you remember, this was thiazolidine ring. This was first, second, third. At third position this was COOH. In cephalosporins, this is a dihydrothiazolidine ring. We call it dihydrothiazolidine ring. Rest of the structure, if you see, is same. We have COOH at this position and this is R1 here. In case of penicillins, I told you at third position only, sodium or potassium, they attach cations. They attach, and what they used to replace, they used to attach with COOH. Here this position is there for changing the nature of this compound, changing the pharmacokinetic properties. And this position, this is rest is same, CONH at this position. This changes the antimicrobial spectrum. If you make changes, if you add something at R2 position, that will change the nature regarding antimicrobial spectrum. R1 will change about pharmacokinetic properties. So this is the difference in structure of penicillins and cephalosporins, though both are beta-lactam and beta-lactam attached with another group. Remember this, beta-lactam is not free. If it would be only beta-lactam, then we call them monobactams. Here the beta-lactam is attached with another ring. In case of penicillin, this was thiazolidine ring. Here it is dihydrothiazolidine ring. Then mechanism of action is same. Need not remember anything else. Just like you remembered in case of penicillin, that in cell wall synthesis, penicillins, they inhibit transpeptidase enzyme by binding, that is actually transpeptidase with some other paraphernalia, I call it. We call it penicillin binding proteins. Cephalosporins also will bind to the same penicillin binding proteins, but remember, there are differences. There are various varieties of penicillin binding proteins, and that is why the spectrum changes. That is why cephalosporins are effective against gram-negative also. So penicillin binding proteins, they are of many varieties. That is why there are differences among members of these penicillins and cephalosporins also. But otherwise mechanism is same. Transpeptidation, pentaglycin binds with L-lysine and D-alanine. Terminal D-alanine is removed. Told you, agla, alanine, glutamic acid, lysine, alanyl, alanine. These are pentapeptide of Parkes nucleotide. Parkes peptide, sorry. Parkes peptide. Parkes peptide is N-acetyl muramic acid with this pentapeptide. Okay, and this binds with N-acetyl glucosamine, and this binds with again N-acetyl muramic acid. This is how cell wall is synthesized. And then this pentapeptide, they bind with each other with the help of transpeptidase. L-lysine binds with D-alanine. Third of one binds with fourth of another with the help of pentaglycine. So remember this is what happens normally. These drugs, they inhibit this transpeptidase, and because of that cell wall is not properly synthesized. If the organism is already developed, it may not make much difference, but if the organism is multiplying, that means more and more cell wall needs to be synthesized, and so they are effective against multiplying organism. So mechanism of action of penicillins and cephalosporins is same, sources are different. In penicillin, I told you Penicillium notatum, Chrysogenum. Here natural source was Cephalosporium acrimonium. Another similar compound, we call it cephomycins. In labs, they are also converted into various compounds related to cephalosporins. That is derived from Streptomyces lactam-durans. Lactam, you can remember, beta-lactam. So this is lactam-durans. So these are two sources of cephalosporins. Remember, nowadays most of the cephalosporins are synthesized in laboratories. The kind of amounts which are required, they are not derived from natural sources. This is all derived in the laboratories, synthesized in the laboratories. Now these cephalosporins, unlike penicillins, we had a different classification for penicillins like acid labile or acid resistant, extended spectrum, narrow spectrum, natural, like that. In cephalosporins, we have gone for a different type of classification, and that really worked, because these drugs, they appeared in the market in 70s, the very first cephalosporins, and then over a period of 70s, 80s, 90s, even now, more and more cephalosporins are being produced. And so what was found to be easier was to divide them in these generations. So compounds which were available in 70s, they were called first generation. Those which were introduced in 80s, they were called second generation. Appeared in 90s, they were called third generation, like that. It was because there was some difference in the antimicrobial spectrum, so this worked. And now you'll find in the books fourth generation, fifth generation. Doesn't make any difference, it's just you have to remember them, which are those compounds and what is the difference. So if you see first generation, cefazolin, always keep a watch on PHA or FA. Never make mistakes in spellings, I keep reminding you. It is very easy to remember things, but when you start writing, then you come to know whether in lactam it is LACTAM or it is LACTEM. Should not happen. Be very specific about where you have F and where you have PH. Examiners, when they check, they get irritated. And if they get irritated, you get less marks. Because if you don't even remember the spelling, that means you have not read it properly. Cefazolin, cephalaxin. Cephalaxin is orally available. I still remember, even when I was studying in 11th, 12th, this was being used, Sporidex. I remember one doctor prescribed me. So cephalaxin, cefazolin, here it is PHA, there is F. cefadroxil, cifradine. These are along with, I have written them separately. Okay, that will come. So these are the drugs you have to remember. They don't have very wide spectrum. They are just, remember, effective against gram-positive cocci. They are not even effective against gram-positive bacilli. Gram-positive cocci and to some extent gram-negative bacilli. This is their only, actually even in gram-negative bacilli, I would say, like I have written here, some Proteus, E. coli, Klebsiella, which cause UTI. So sometimes you can use it in UTI. Problem is we have so many options for UTI. So why to go for these drugs? So these drugs are practically effective against gram-positive streptococci, MSSA, methicillin sensitive Staph aureus, not effective against MRSA, which cause soft tissue infections, skin infections, furuncles and other. So there you can use it. Cefazolin actually is used as a single injection. Remember, in surgical prophylaxis, we give one injection just before the surgery, before incision is made, and that single injection, cefazolin, is used. Endocarditis due to methicillin sensitive, we can combine them with some other drugs. That is a different thing. Just like I told you last time, I am just talking about where it can be useful. And then cephalexin, upper respiratory tract infections. Again, you have so many choices. For pharyngitis, for otitis media, you have so many choices. So there is no need for going, but cephalexin orally available, it can be used. So these are the only uses of first generation, and this is the spectrum. Streptococci, to some extent Staph, MSSA, and the organisms which are causing SABE, Streptococcus viridans and others, they are causing SABE. So some species of streptococci, some of staphylococci, they are the only spectrum of first generation. Second generation, Cefaclor, Cefprozil, Cefuroxim, Exetil. Exetil is available for oral use. These are along with, you can remember, as cefoxitin and cefotitan. These are other drugs. So in every generation you remember 3-4 examples, because whenever you are asked about classification of cephalosporins, when you say first generation, you should write some examples. So in second generation, remember, but remember, second generation drugs, practically you will not find them being used. Why? Because you have third generation. The reason is, if you see second generation, in gram-positive cocci, Streptococcus pneumoniae, that cause pneumonia and otitis media, but as I told you, you have so many drugs available for this. I have written not better than amoxicillin. So you have amoxicillin, why to go for them? Their main uses you will find are, I would say, gram-negative bacilli, though effective against gram-negative cocci also. But again, gram-negative cocci, we only talk of gonorrhea. But why would you go for second generation for gonorrhea? You have a long list. Even ampicillin single dose is effective against gonorrhea. You have third generation. So why to go for second generation? But effective. Gram-negative cocci, gram-negative bacilli, but remember, they are more effective against gram-negative bacilli. And they are Proteus, Klebsiella, E. coli, Haemophilus influenzae, Moraxella. I have specifically taken these organisms. Why? because if you remember them, the same organisms will be in third generation also. Easier to remember. Proteus, E. coli, Klebsiella, Haemophilus, Moraxella. They are gram negative, sensitive to second generation, and they cause community acquired pneumonia. Then these are the drugs. Cefoxitin, cefotitan, that you can use parenterally. They are used for perioperative prophylaxis for intra-abdominal and gynecological surgeries, peritonitis, pelvic inflammatory diseases. So these cefoxitin and cefotitan, they are used parenterally for perioperative prophylaxis and for intra-abdominal infections because of gram negative sensitivity. So second generation also, they have limited utility. Third generation, these are the drugs which were used for a long time and even now. Cefotaxime, ceftriaxone, cefdinir, ceftibuten, cefpodoxime proxetil, ceftizoxime. These are third generation. They are gram negative bacilli and Neisseria cocci. So gram negative organisms. Neisseria I must have written later, so it is included in negative bacilli, but it's a cocci. Remember, third generation, in many places they are drug of choice in gonorrhea also. So gram negative cocci and gram negative bacilli, all of them. Proteus, E. coli, Klebsiella, Haemophilus influenzae, Moraxella, Catarrhalis. What is added are Citrobacter, Enterobacter, Serratia, Streptococci also, so they are gram positive, and MSSA. So effectively, the organisms which were covered by first generation, Streptococci and MSSA, and which were covered by second generation, they are also gram negative bacilli, they are also covered. And in addition to that, you have Citrobacter, you have Enterobacter, Serratia. So these drugs are, when remember they were introduced, it was said they have broader spectrum, but they were mainly used against gram negative organisms. But Streptococci and Staphylococci, they are sensitive. So they have very good spectrum. The thing is that these drugs are not used empirically for all infections. These drugs may have limited uses, but they are used for life-threatening infections. That you will have to remember. Community acquired pneumonia, and here I have written empiric treatment of meningitis. You don't know which is the organism, so this is covering almost all organisms which may cause meningitis, and so this is the empiric treatment of meningitis. You go for third generation. And gonorrhea, I told you, many places they are drug of choice nowadays in gonorrhea. So few uses, spectrum is quite broad, that is third generation. Then comes many books, they have written fourth generation, but I prefer and easier to remember. I would rather call them anti-pseudomonal cephalosporins. You call them fourth generation or anti-pseudomonal cephalosporins. So they are drugs like ceftazidime. Ceftazidime is gram negative, similar to third generation. This is added. Pseudomonas, opportunistic infection, life-threatening, septicemia, UTI, respiratory, all kinds of infections you will find hospital acquired. And so Now fourth and fifth generations, you will find are being used against these serious infections, life-threatening infections. So fourth generation is anti-pseudomonal. So specifically I have written poor activity against gram-positive. So fourth generation or anti-pseudomonal, they are, so ceftazidime. Now this ceftazidime avibactam and ceftolozane tazobactam. Remember this tazobactam, last time I told you it's a beta-lactamase inhibitor. Beta-lactamase, I told you they were plasmid mediated and chromosomal, inducible. So some of the organisms, they have developed beta-lactamases which are destroying even cephalosporins. So here we have this combination of ceftazidime with avibactam. Avibactam is there, you can add. At that time I told you about 3: clavulanic acid, sulbactam and tazobactam. Avibactam you can add. Avibactam combination is available with ceftazidime and ceftolozane is available with tazobactam. Then it becomes multi-drug resistant enterobacteriales. Bacteriales is a genus, larger, that includes enterobacter and similar compound. Very dangerous hospital acquired infections, opportunistic, various kinds of infections including UTI, respiratory tract infections, abdominal, septicemia. So very dangerous hospital acquired infections, and this combination is effective against them. Cefepime, comparable to third generation but resistant to beta-lactamase. So that increases its utility of cefepime, just like third generation but resistant to beta-lactamase. Remember, these drugs are not effective against MRSA. Methicillin resistant Staph aureus, not effective. Cefiderocol, similar to ceftazidime but also effective against Acinetobacter. Another hospital acquired opportunistic infection. I have specifically written ventilator pneumonia. The person is on ventilator, because of that if the pneumonia is developed, then it is, remember why they are so problematic, these infections in the hospitals, because they have been exposed to many drugs already. All beta-lactams they have overcome. That is how they survive there. So these infections, they become very problematic. So Acinetobacter causes this, and septicemia, UTI, all these are caused by Acinetobacter. Remember, Acinetobacter, Enterobacter, even Pseudomonas, you will find almost same types of infections which are caused hospital acquired, opportunistic, and almost same types of, like all of them, they cause septicemia. Then anti-MRSA cephalosporins, or you can call it fifth generation. So specifically like ceftaroline fosamil, ceftobiprole, midocaryl, these are anti-MRSA. So specifically this fifth generation, they are effective against methicillin resistant Staph aureus. Otherwise rest of the spectrum is like third generation. But these are the drugs which are effective against MRSA, 4th generation R nodes. So these drugs you can remember, ceftaroline and ceftobiprole, they are effective against MRSA. Adverse effects. In penicillin, we talked about that they are safer drug. Even cephalosporins, they are very safe. All these adverse effects, they are in very few people. But first I have written hypersensitivity. I won't say there is cross sensitivity between penicillins and cephalosporins. There is the incidence of hypersensitivity of cephalosporins is very less. That is why actually we don't go for hypersensitivity testing. In penicillins even today, we are doing that scratch test or whatever for checking the hypersensitivity. But you should be careful. If the person gives history that he or she has sensitivity to penicillins, then you have to be careful. Particularly, I don't know, but you can remember some of them. Remember that this hypersensitivity is because of side chain. So we can find out that if this person is sensitive to this penicillin, then this would be sensitive to this cephalosporin. Like we'll give some example of ceftazidime that has cross sensitivity with those penicillins, side chains. So, but if the person gives history of hypersensitivity with penicillins, then be very careful. Otherwise, they are same, reactions are same if it happens. There is immediate type of reactions and there is delayed also. Immediate like angioneurotic edema and those severe types of decrease in blood pressure, all those things can happen. Delayed also, it can happen that presents with maculopapular rash and urticaria. So all types of hypersensitivity reactions which are seen with penicillin can be seen with cephalosporins also. Pain at injection site and thrombophlebitis. Remember, we don't consider it when the patient is admitted. Ceftriaxone is being used at such a large scale, and you will find what they are doing, they are just pushing it. Extremely painful. Extremely painful. You have to be very careful, should give it slowly or give it diluted, whatever you want. Otherwise, thrombophlebitis, somebody can do this study. How many patients who are being given ceftriaxone in hospital for a week or for some time, how many of them have swollen veins? Many of them you'll find. We don't consider it basically. We always feel that we are doing a favor to the patient. We are treating him. But these are important things. Pain at intramuscular sites, actually in many in front of many drugs you will find it is written that not given intramuscularly. Why? Because painful, extremely painful, irritation, local. Sometimes the volume is too high also, but many of them are not given intramuscularly, effectively all of them. I would say so to some extent cefotaxime does not have that much phlebitis or something, but otherwise I have written specifically because they cause a lot of phlebitis, ceftriaxone, cefoxitin. But we have to be careful. Positive Combs reaction means it's an indication, but hemolysis is very rare phenomena with cephalosporins. Bone marrow depression, granulocytopenia, another rare, but I have written them in the beginning because if they happen, then it is problematic. Very rare, but they are serious effects. Rarely renal toxicity also, nephrotoxicity is there. Now we come to these. Diarrhea in case of penicillin, extended spectrum, amoxicillin, ampicillin, becampicillin, talampicillin. I told you diarrhea is a big problem. Here also diarrhea, which is more with cephopyrazone. Why? Because it is secreted through bile. So more of it is available in the intestine, and because of that there is diarrhea. So otherwise it is surprising when I am giving the drug parenterally, why there is diarrhea. That is why I have specifically written it here, that with drugs which are given parenterally there can be diarrhea. The reason is they are excreted in bile. So cephopyrazone, there are one or two more drugs which are excreted in bile, and because of that there is diarrhea. Now this displaces bilirubin from albumin. In neonates this becomes problematic, kernicterus. And another, it gives me an example of high protein binding interactions. So ceftriaxone, be very careful when you are using in young children, neonates. This can, that is why actually in children again cefotaxime is supposed to be a safe drug, does not have that much protein binding. Ceftriaxone, it has protein binding and this displaces bilirubin, acidic drug, and because of that kernicterus in neonates. Biliary pseudolithiasis, ceftriaxone. I gave you example of drug that is secreted through bile. What was that? Cephalosporin. Ceftriaxone also. It is excreted in bile huge quantity and this causes biliary pseudolithiasis. Because this binds with calcium also, ceftriaxone. Prolonged prothrombin time, so increased tendency to bleeding, particularly seen with drugs having thiotetrazole group as side chain. Cefazolin, cefamandole, cefotitan, these are second generation. So these drugs, they may have increased prothrombin time, because of that increased bleeding tendency. This cefoperazine is also there. So in these drugs you have to be careful. Encephalopathy and non-convulsive status epilepticus. Cefepime. Otherwise cefepime is a very safe drug. Cefepime is fourth generation. So otherwise it is pretty safe, but this is the problem with cefepime. And disulfiram reactions also seen with cefoperazone. When you consume alcohol, then it causes extra side effects, so that is disulfiram like reaction, that is also seen. So remember these adverse effects of cephalosporins. And we come to carbapenems. Carbapenems, I told you, this is the beta-lactam ring and this is the another ring to which it is fused. This does not have S, so it is not thiazolidine ring. This is a 5-member ring, so we call it carbon ring. There is no thiazolidine. It's a carbon ring, so this is the structure of carbapenems. Here you make changes, R2, R3, you make all these changes and you get different types of drug, but not many of them are available. These are the drugs available. Imipenem, carbapenem, meropenem, ertapenem, daripenem. Imipenem. The problem with imipenem is, meropenem also, they are not destroyed by beta-lactam. Remember, they are not destroyed by beta-lactam, but they are excreted in kidney. They are excreted through kidney. In brush border of kidney, there is one enzyme, dipeptidase, that causes degradation of this drug and in huge quantities. So what we do, we add silestin. This is the inhibitor of this dipeptide. So in case of imipenem, we add silestin because of same half-life. Another drug is Carbapenem. This is, I told you, may not be destroyed by beta-lactamase, but some of them, in some of the organisms, carbapenemase, we can call it, that is the enzyme, just like beta-lactamase, is produced, that destroys it. So we have solution for that also, that is Carbapenem. This causes inhibition of that carbapenemase. So these combinations are available. Relebactam is carbapenemase inhibitor and celestin is dipeptidase inhibitor. We add all these things. Meropenem is combined with Carbapenem, another dipeptidase inhibitor. Ertapenem become important because of once daily dosing. Rest of them are given 3-4 times a day. Very small half-life, 1 hour, 1.7 hour, like that. Ertapenem is given once daily. It does not mean it has 24 hours half-life. Remember, all these penicillins, cephalosporins and all these drugs, their half-life you will find in the range of 1 hour, half an hour, 2 hours, not more than that. But they are administered twice or 3 times a day. Why? Because we are giving huge quantities. So even if drug keeps coming down, even if you give twice, thrice a day, the concentration is above minimum inhibitory concentration. A lot of studies has been conducted on this, how many times penicillin should be given. But now it is done that we give huge quantities and wait for, like in case of even simple penicillins, we go for at the most 4 times a day, not more than that. So these drugs also, they don't have that half-life is 24 hours, but ertapenem is given once a day. Daripenem, I don't think we have it and we use it. Same, like pen, they are also beta-lactams. Same mechanism of action, there is no difference, I won't repeat. Effective against wide variety of aerobic and anaerobic. Remember, broader spectrum, and that is why one of the adverse effect is Clostridium difficile superinfection. That is superinfection because all organisms are killed, so this Clostridium difficile starts growing, and this causes, Clostridium difficile causes diarrhea, dysentery, all those in the GIT. So Streptococci, staph, listeriosis is food poisoning like picture it gives. Available, like you'll find a mild form, and in severe form there can be even deaths. So listeria, Neisseria, Enterobacteriales, Pseudomonas, Acinetobacter, Bacteroid fragilis, first time I have written, Nocardia, nocardiasis is another serious disease, and even mycobacteria. So spectrum is very broad, but comparatively you will find the uses are very less. Why? Because you cannot waste it for normal infections. When such organisms are involved, it is effective against them. Then these are the diseases. One is empirical treatment of hospitalized patient. When you don't know what is happening, you go for them. Go for imipenem plus combinations with celestin and relebactam. Go for that combination. Urinary tract infection. Again, I am saying it's not that the patient comes to you, I have burning micturition and you give carbapenems. No. When I am talking about serious hospital infections. All these infections should be in hospital if you are using carbapenem. It's not to be given on OPD basis. Urinary tract infections, respiratory tract infections, gynecological infections, intra-abdominal infections, soft tissue bone joint infections, all of them broad spectrum, but as I told you, use them very cautiously. These combinations are reserved for gram-negative infections resistant to all antimicrobials. So remember, combination of imipenem with relebactam and meropenem with Carbapenem. I think when I was talking about this combination meropenem with Carbapenem, I said Carbapenem is dipeptidase inhibitor. No. Meropenem is not sensitive, is not combined with silestine. It is resistant to that. Vaborbactam is carbapenemase inhibitor. So this combination of imipenem with relibactam and meropenem with vaborbactam, the name Bactam in this, it gives us some idea that it is effective against beta-lactamase, but this is not beta-lactamase in this case. This is carbapenemase that destroys, that is produced by some of the organisms and destroy these drugs. So these are the drugs which are reserved for all resistant infections, gram-negative. And the last one is monobactams. Monobactam, I have specifically taken this. See this. This is the beta-lactam ring. It is not fused with any other ring. This is independent. Though it contains thiol group here, but this is not a ring. This is open structure. So when beta-lactam is not fused with any other ring, then they become monobactams. We don't have many of these drugs. Aztreonam, mechanism of action is same. They are all beta-lactam. So there is no difference in mechanism. They are comparatively having very narrow spectrum. Effective against gram-negative bacteria, no activity against gram-positive and anaerobic bacteria. So only gram-negative. I have not written even the name. Aztreonam, Aztreonam. Aztreonam is the drug. That is monobactam. So no cross sensitivity with other beta-lactamase. That is the advantage. If the drug is not effective against penicillin and it is a gram-negative, you can use Aztreonam. Used in metallo-beta-lactamase producing gram-negative infections. This is a specific type of beta-lactamase. So other drugs, they become resistant. In this case, you can go for this. Inhalational. This is unique thing about Aztreonam. Inhalational preparation is used to reduce frequency of pseudomonal infections in cystic fibrosis patients. So you go for inhalational route in these cases. This decreases the frequency of infections. Hospital acquired UTI, biliary, abdominal and gynecological infections. So again, serious hospital acquired gram-negative bacilli. All these are infections caused by these organisms. Then we come to about few of the side effects of these carbapenems and monobactams. Remember, monobactams and carbapenems, they have few of them are very few side effects and some of them are common. That is why I have not covered them along with them. Remember some GI symptoms: nausea, vomiting and diarrhea. Both of them will have. Second is hypersensitivity reaction in the form of hives, rashes, urticaria. Maybe immediate or delayed, though rare in these cases, but that is seen with both of them. What is unique in carbapenem? Carbapenems, they decrease the threshold to seizures. That is not seen with monobactams. So that is a unique side effect of carbapenems. They decrease seizure threshold. Otherwise, these drugs are quite safe. So thank you very much. इसके बाद में नेक्स्ट कौन सा होने वाला